I told my buddy, like, hey, I'm going to be in slow. If we're doing anything tonight, like, just let me know. And he's like, yeah, just let me know when you're done, and we'll do some tacos. My roommates were originally going to go, but they got family night,
Is this too bright for you?
No, it's okay. I'm just like... Yeah, studio situation. I like that you have the light setups are pretty cool.
Thank you. And honestly, like, to have decent video, I feel like it's more dependent on the lights versus just like having a camera.
Dude, lights are what's up. I have for like originally it was a gaming setup, and now I use it for my school situation, but I bought like the Philips Hue lights that like sync with like your app, your computer. And I also have like my overhead lights like that, and I originally got them for my eyes just for backlight, so it'd be a little more comfortable. And they sync to the screen. You set up where they are in relation to your screen, so it kind of extends the effect of like when you're gaming. If you're looking over a green field, they're like green. You look up, they turn blue with the sky.
Are you serious?
Yeah, they're legit, super fun.
How much were they?
Normally they're really expensive. I think they're like probably like $100 a piece, somewhere in that. And I have 3 lights. Damn. But I got them on eBay probably like under $50 each, and I've just got all the pieces and set it up. My most common use for them actually is they have like these lab there's this lab app on there where you can set like a simulated sunrise time. And that's my favorite because I have an alarm just in case I don't wake up, but it starts with like a dark blue light, and it goes all the way up to like normal light, and it simulates a sunrise. It's sick. Like I wake up literally within the same 10 minutes every day without, like, very rarely does my alarm not get me up, or do I have to actually listen to my alarm go off. And it's just like such a relaxing way to get up versus, the freaking loud Apple alarm sound. It's just like, oh gosh.
That must be good for your, like they say to have like a good morning wake up, you're supposed to look at the sun for like your retina or something, and that releases a certain hormone that goes like, okay, it's time to wake up.
Exactly.
So that's why when people work like super late at night or the night shift, when they see the sun come up in the morning, it like tells you to stay awake. So I guess it's like harder to fall back asleep.
Yeah, you stay going. For sure, working night shifts was really hard for me. I tried all of the things to like, stay sane with like my sleep work schedule. But yeah, I do like it. I believe, I don't remember what the hormone is, or if it's just like the lack of melatonin
or some shit.
Yeah, cortisol, because they test like the AM cortisol level to test like your adrenal function and things like that. So I wouldn't be surprised if that played into it. But the light coming in, usually it hits me in the like when it's like blue, just kind of turning warm. And the nice thing too, if it's blue, I know I'm like, oh, like I can still lay here until it's like a warmer color. But it's just so gentle waking up that way. Although I forgot to turn it off last night because last week I worked these days. So I did wake up like earlier than expected this morning. I saw that it was blue and I was like, I turned it off and tried to go back to bed, but I was already kind of awake.
It was probably mad at you. It was like, wait, don't turn me off yet. Like, I'm supposed to turn back on tomorrow.
Totally, yeah.
And, I guess I kind of recently started getting back into... I went hard for a couple years, and, like, this was my thing. Like, I'd get off work, I'd interview somebody, like anywhere from like 1 to 4 times a week.
Oh wow!
So that's why that was just what I was doing for literally almost going on like 2 years. But then school started, and I was like, all right, ditching this, and I took like a 15-month break.
Wow.
Of just like not doing any YouTube stuff, which was cool. Like I focused on different outlets in my life which needed to be focused on, and then one thing kind of led to the next, and I interviewed a couple people, and I was like, okay, like school year's wrapping up, we're about to graduate, like why not just shoot a shot in the dark and try and get you on that honestly would add a different element to this when we start talking later on and like getting deeper into some subjects. And like I feel like you genuinely like to teach too, so like you would be like I was like, okay, I do want to interview Eli.
Sick.
You know what I mean? And like that's literally like what inspired this, and I guess my kind of opening things to like get things started in the direction I want to head in is so you are a registered nurse.
Yes.
Okay, and you work, and you don't even have to say where you work if you don't want to, but you work in a hospital.
I do, yeah.
And you before that you were a pharmacist, you said, for 5 years.
Phlebotomist.
Sorry, not phlebotomist. They both started with a P. Phlebotomist.
For sure. That'd be an interesting direction to take. Going from pharmacy, just like, I can't. Let's go to bedside nursing. Yeah. I'd be curious if any pharmacist has ever thought that. It would be interesting. I feel like people who go into like pharmacy or lab, they tend to go there because they may have those like introverted personality types where they kind of like their non-patient population area, but there's obviously people on either ends.
Yeah. How what got you into nursing?
Oh man, that's a really interesting story. I mean, the most basic answer is just that in high school, when I was kind of looking at colleges and classes and majors and things like that, I kind of had an idea of what types of classes I enjoyed, which was like all of them. I like science. I like to apply a ton of things to what I was doing. And when I looked at prerequisites for nursing, kind of what it sounded like it was, I was like, oh, this is a very kind of all-encompassing field, And that was just really appealing to me on that end. But then I also had this kind of, I noticed my dad, he's an electrical engineer, and my whole family, they're all engineers and very, very intelligent and very focused on work and do really cool things. And as a kid growing up, I just kind of thought maybe I would go that direction, and it seemed appealing. But as I got into high school and had more of like a social life and friends became more my focus, I realized that the men in my family, super successful, smart engineers, like their social lives, they have their small group of friends, but it really wasn't as appealing, like what I would want for my whole life kind of situation. And I kind of had toured my dad's work and saw the tools and things they're working on and the way they interact with each other. And growing up doing sports and things, I was like, I want to be in a more active team environment where we're physically doing things with people, So that kind of general idea pushed me towards like, oh, well, nursing seems to contain these things. And also at the same time, my dad being a very practical person was just like, I got into like UCSB for biopsych, which was like a really good program there. And I was super excited about it. And he's very practical. And it's just like, okay, what job are you getting after that? Like, do you have a plan? Does that make sense? And I was like, no, I don't know what a biopsychologist does other than would maybe teach biopsych one day. So he was pretty much like, you're welcome to do that. Take out loans, go do that if you want to do it. And I'm like, oh, yeah, I'll go to a community college instead. And, nursing just seemed to have a lot of the components that I was interested in learning about, but applied. And that's where I started looking at, okay, what are the things about nursing that make me uncomfortable? At the time, I wasn't quite as good at talking to people, I feel like. Not that was very scary for me. Part of my personality is I tend to actually like lean in or just kind of stay and observe uncomfortable situations. And the main thing for me was I knew when I get a blood draw, I will straight up pass out. Like I will get lightheaded. I can't look. I just don't like it. So knowing that, I was like, okay, what can I do to kind of prepare me for the RN program, but also overcome this fear of needles? And it's like, oh, phlebotomy, it's a 2 birds, 1 stone. I can get some medical experience prior to going in. I can also just see if I can handle the thing that seems scariest to me. And I just remember it like it was yesterday. I remember getting into the phlebotomy program. I remember doing, you do your paperwork, your MMR, and they do the little bleb and everything, And up until this point, I'd never watched before. I always turn my head. I'm like, oh man, okay, deep breaths. They like lay me down and stuff. But this time I was like, okay, I'm going to be a phlebotomist. I'm going to watch this. I'm like, all right, here we go. I'm watching. And just like stars. I'm just like, oh God. And, you know, they get me to come to in the office and are just kind of like, you know, like this might be a sign. Maybe you should like think about something else. Or I'm like, maybe, you know. And I went to the class, and then the first class they do too, the teacher was very intimidating and just kind of like, okay, anyone here, like basically be ready to be sued. Like patients are going to come after you if you poke them wrong. They just had this very like fear-based first day. And after that, more than half the class was there, but maybe a third, a significant amount of the students were very just like out of the way from that. And it was interesting. Looking back, I think it was just kind of a like, the teacher wanted people there who were serious and like really wanted to do things right and do a good job and keep them to a high standard in their phlebotomy practice. And went through the class. It was really very detailed for a very specific skill and learning situation. I love phlebotomy. I mean, when we got to the practicing on each other portion, they figured out I always had to go first because whenever they'd poke me, I would get like lightheaded and they'd have to wheel me outside, fresh air. And it was actually a good learning experience for the class because they're like, oh yeah, if you want to see what to do when your patient is a weenie, basically gets lightheaded, we'll practice on Eli. So I was accepting of it. And then when it came to drawing other people, I didn't have a problem. I was like laser focused. I was very empathetic and just like, oh man, like I know how much this sucks. So I'm going to try to do a really good job to make this like, you know, as painless as possible for what it is. But yeah, I overcame that and worked in outpatient phlebotomy for a handful of years. Eventually got into the RN program, and then I switched over to hospital phlebotomy. And then very anticlimactic becoming a nurse as far as the job transfer. I was expecting like an interview, all this stuff. I interviewed a few hospitals. They all offered me positions in either like a med surg or step down type area. There's also pediatrics I was originally interested in, but it was all the way in Marion. In our area, we just don't have very high acuity pediatrics, and talking to higher mentors at the time were just kind of encouraged me either do an ER or med surg. It's just going to be a lot better experience going. If I did eventually want to do pediatrics at like a large children's hospital or something, it's going to look better having like being able to handle a larger med surg population than one or two peds patients with very simple issues like a lap appy, RSV, just kind of very basic. And because I did do an internship and preceptorship at Marion, and like half the time I was watching Disney movies. I mean, it was awesome, but definitely I kind of knew my skills wouldn't develop as well in those locations.
What's your favorite Disney movie from that experience?
From that experience? Oh, man. I think at that time, from that experience, it was probably like Mulan. There was like some older ones. And then more recent Disney movies, there have been some pretty fun ones as well. I really liked the Turning Red. I thought was pretty cool, actually.
What was
it's
that
like
one?
A Pixar. It's got a red panda in there. It's essentially a story about a girl who's like coming of age with her menses and stuff, was like an analogy to it, but through Disney basically. And also I think Chinese American family, and kind of like the different pressures that she was facing and things like that. But I don't know, I like cultural stuff. I've been going to Cuesta for a long time. I did a bunch of random stuff. One of the classes I took was like a cultural nutrition class, and that was just like, I loved it. I love cultural food and learning about different cultures, and it's definitely a little bit of a hobby of mine. Like when I listen to podcasts and stuff, I like to learn about that stuff.
You What podcast do you listen to? Like name, it doesn't have, don't name your top one, but name one of your top three.
Yeah.
If you listen to multiple.
I listen to quite a handful. I really like How to Become a Better Human. It's put on by like TED Talk.
Okay.
And they just interview different experts in their field, and it's very broad. I mean, they go from like comedians to like neurophysicists. I mean, it's just like all over the place. And just kind of their suggestions on life, or what they think is, what they recommend to be a better human, things like that.
Gotcha. Is it like science-y hormone type stuff, or is it more like chill talking, social stuff?
It's in between. I listen to some that are way more on the science side, like Huberman Labs, which is he's like a Stanford professor, does neuroscience stuff. That one's recent. My coworker recommended me that one. But yeah, they're usually on the educational side, and how much I'm listening to them is waxes and wanes with how focused I am. Sometimes it's just noise and kind of helps me along with the drive, I also like just ridiculous. There's this one, Last Podcast on the Left. They do like cults, serial killers, aliens, like just really interesting, gnarly topics, basically. So that can be fun every once in a while as well.
And then, so when you were in the nursing program for 2 years, you were also working as a phlebotomist?
I was, yes.
So that's where 2 of the 5 years were.
Yes.
3 years of a phlebotomist. You applied
Correct.
to the program a couple times.
Yes.
Got in, continued what you were doing part-time.
Yes.
And then you graduated in 2019?
Correct.
Okay.
Yeah. So yeah, right before COVID.
And then you've been working at that one place the whole time?
At Twin.
Okay. And can you tell us about that? Like your experience being a new graduate nurse back in 2019, and then kind of run us into what started happening with the pandemic and like how that was, because 2019 when you started working, it seemed like it was probably normal for the first 8-9 months to a year, and then things started getting rambunctious.
It was very oh man, what a wild time. So I graduated in 2019, went from, like I said, it was anticlimactic. We did the interviews, but for me, since I already worked there, it was literally a transfer form. Like I signed that I'm going from phlebotomy to this other department. I just signed a paper.
Oh yeah.
So there was no interview.
They had your back.
Yeah, they were open. They were like, hey, you want ER? Like, where do you want to go, kind of thing. And at the time, I was like, whatever is the best experience to go towards, like pediatric hospital, something like that. They heavily suggested med-surg is going to give you're going to have 4 or 5 patients. There's going to be the most variety, and it's the most like hub of nursing. ER is kind of its own specialty. A lot of nurses, you go there, it's hard to change your mindset and get out. But very fast, very efficient. A lot of new nurses do great there too. So I was like, okay, well, I'll go ahead and do med-surg nights. We start in July. I think it was, my license actually posted July 4th, and then it was sometime in July that I think within the same week, they're like, your license, cool, let's go. You start with a cohort. My cohort was, I feel like 6 people got hired, somewhere around there, between 6 and 10. And the new graduate program was really cool. It was much better than I expected. I remember coming out of school and being terrified to in my mind, I imagined like going on, like entering the floor as most jobs I've started, where they'll give you a day or two and they're like, okay, now you're working. But there is actually like a somewhat of a residency new grad program. We were paired with hopefully just a single preceptor who's really respected and established, kind of get your flow going, get you up to the right amount of patients. And then you're also not working the full 3 days. You have like a half day every week of like didactic lecture type stuff where wound care nurse will come in and kind of explain, okay, this is what we like to see. This is how you should create your dynamic groups to chart these wounds, to just kind of everyone be on the same line. And that went on for a handful of months. I feel like it was around November when we were like fully on our own. The last month we switched over to nights, and you got a month, I feel like, precepted on nights, which was also, as a new grad, just really a breath of fresh air at the time. I was feeling kind of overwhelmed with when you actually have the phone on you and the access to everything. It's just kind of overstimulating, like too many things to do. And I don't know, for my brain, like my family and them all doing their engineering things, like they work on these projects, like single projects for years. So to go from like that type of just dinner conversation and stuff like that and how our household worked to like, oh yes, every day is like 5 new patients and I don't even know what's happening until hopefully the end of the shift. I'd show up early every time and get like a little bit going. But that going to nights was a nice to just focus, like, okay, I got show up, I can do a little bit of research, I can do my assessments, can do my med passes, and then have usually a good amount of time to chart up until sometime middle of the night. People start waking up moving in that like 4 a.m. to 6 a.m., which is rough when you're working because, you know, that's towards the end of your shift and you're kind of starting to... I never really felt like I was nodding off. It was definitely stimulating enough to like get me through the whole thing quickly. But, you know, that last hurrah at the end of night shift was always just like, oh man, people waking up and... But basically, right around that November time was when COVID kind of started existing here. Like it was late in 2019, and then like kind of through 2020 is when it started really going. And COVID hit, man, that was like such a wild time to be a new nurse because I like kind of just came off of orientation, was just feeling like I kind of knew what was going on. Standards felt pretty high of like, oh, everyone's constantly coming to me, telling me, okay, this is what you need to chart on. These are the things you miss. You know, these are the things you're doing great at. And I was doing well. And then COVID hit, and all of a sudden, basically what happened is we have this thing called a medical guard unit where I work, which is normally used for prisoners and like psychiatric state hospital patients. So it's literally prison unit. I mean, barred windows. There's a sally port to go in. We drop off any phones, anything. The nurses' station's behind bulletproof glass. No seats on the toilets. Nothing you could like pull off to like use as a weapon.
How do you sit down on the toilet? You don't?
It's just like a
toilet
fixed
rim.
Fixed bedpan. Like think of that. It's just this metal thing like that. It's designed to have 2 guards in the room at all times, and there's no light switches even. The light switches require a key outside to turn the lights on. Yeah.
Gnarly.
It's quite an environment.
Prison.
Yeah, literally prison. No call bells either. The call bells are the guards have them normally. Like it's wild. Anyways,
you just hand it to them. You're like, hey, press this.
So this is a little bit like when COVID. They were trying to figure out how to make it safer because basically the MGU bed, they do have they're hooked to the wall. They're a little bit different. They have a special connection, and they have, because the patients are supposed to be chained to the beds normally, have 2 restraints on at all times, any extremities. But they're usually able to, like, if they need the call button, they can press it basically with their hand on the bed, but there's no like regular button. But we ran out of MGU beds. Like there just weren't enough for how many people we were putting in the COVID unit. And also the nurses' station's behind bulletproof glass in this like little corner. So there were just issues with, you know, not being able to see or address the patients fast enough. And the solution was that someone went out and bought a bunch of the restaurant ringers and just like gave them to all the patients. And I feel like I have PTSD from those things because, like, whenever I'm in a restaurant or I hear someone goes, I'm just like it takes me back to being like gowned up, and I'm just like sweating, like, oh, because like I remember you just be sitting in the station or like out there, and you just hear like, and some people they're confused or they're scared because it's a prison and they're already demented, don't know where they are, hypoxic because of the lack of oxygen a lot of times, and they're just like, no, look at this bell, like ding ding, they're just slamming it. And yeah, it was rough because it's like they need a way to call you too. But yeah, it definitely just like shook practice up a lot at that point. We and eventually state shut that down too. Like once things got calm enough where not everyone was like on fire, they came and were like, hey, you can't use that unit for COVID patients. Like this is just not okay, basically. And we're like, yeah, we agree, this sucks. The concept, I would say, for any new nurse who's just thinking about what it was like, it's just like imagine having an entire extra unit of patients and no staff hired for it. They just suck resources from everywhere else. So every unit was actually pretty terrible to be on. And COVID actually, I remember when it was at its worst, and because it was like kind of scary and new, I preferred to be in the COVID unit because they would pull so many resources from the other units that like at least you were in like a confined unit with, they would try to keep your ratio at 4 or 5 too. You wouldn't go out of ratio as much in COVID. Breaks were pretty much out of the question. You would go from when you got there until the end. And it was just like, you're just waiting for night shift to show up and then just be like, oh my God.
Literally hoping they show up.
Yeah.
Would you have to stay? Did you ever have to stay over?
Yeah, if someone was late or something. I mean,
okay.
Yeah. Or like management, our director is really awesome, and she would come in sometimes and like middle of the night and just help out. So it was like all hands on deck, helping out. Practice was really different at that point too, because normally we're taught all of these things like, oh yeah, you're only going to pull one med at a time to like prevent mistakes. The one nice thing about the COVID unit, and don't practice this way, but since every patient in there was COVID and there was a Sally port that like separated it from the whole rest of the hospital, we would gown up in the nurses station and then be gowned up and be able to go in between the patients and just do hand hygiene, like with our gloves, wear extra sets of gloves in between patients. So you'd gown up once. And with that, we would take bags, label them, and do like get each patient med in like a separate bag. And it felt so wrong because I was a new nurse and just like, oh my gosh, like I should only have this one patient's meds on me, But
you'd have all four
or five, yeah, okay. Just in separate bags.
Okay.
Yeah, so it was our workaround. Luckily, never made
to save time.
Yeah, because otherwise you're gowning up completely, going out, de-gowning completely, cleaning, going in, gathering meds, gowning up completely. It was, which other units did do things like that, like the ICU and DOU at the time, the ones that they had on ventilators were up there. We would go up to BiPAP in our COVID unit. So a lot of people on Airvo, BiPAP, high flow cannula. But it was awful. I mean, people were just so scared, and I've bonded with patients before who've come back and are just like, oh my gosh, like, do you remember that COVID unit? Like, I have PTSD from that thing. I'm like, yeah, me too. Those were rough times. Like, ugh. Yeah, it's kind of wild too, because the worst part was when I think back on it, wasn't even that necessarily, because it was like I would talk to my coworkers afterwards and we would kind of just like trauma bond a little bit, but just trying to be around like people in real life during COVID, like my family. I was living at home at the time, and I would go through this whole routine of like going straight to the shower and like cleaning, sterilizing the shower and all this stuff. And I was working nights too, so if they're moving around the day, it could be disturbing. And they're just hearing about their struggles of being like, oh, we've kind of ran out of places to hike at because, we've just been getting paid a lot to stay at home during COVID. And I was just like, wow, that is like such a different problem than what we're dealing with at the hospital. And then in the hospital, the hardest thing I would say is actually the families, because
wanting to see their patient who's in like a secluded part of the hospital.
Yeah, and they would actually try to like break the windows sometimes. You'd like see them kind of out there. Like some families were really, because I mean, there's a lot of controversy. Like some people didn't think it existed.
For sure.
So there were people there who didn't think it existed, and they're just like, "What are you hiding?" And it's like, dude, trust me, we are just working our asses off here. Like I want everybody out of here too, man. And the hardest thing I remember were the phone calls afterwards, because we would be so busy the entire shift, and then we'd have like messages on the phone of people just screaming at us, basically, just like, "What are you doing? Like, I haven't gotten a phone call all day. Like, are they even still alive?" All this intense stuff, just like yelling understandably, at nursing staff, whoever took them in. And we'd have to be off shift, basically, like when the night nurse took over, and be like so tired, just like, "I'm sorry, I'm just getting to the phone now. I've been, you're drenched in sweat in your isolation gown, just like, I did not have time to call you. Now someone else is on, I can call you. Like, this is where they're at in their oxygenation." And that was the other hard thing, is in school we learn all these treatments. Mm-hmm. And with COVID, like, we didn't really have treatments. We were basically just waiting for them to progress into ARDS, acute respiratory distress syndrome, and like be on a vent, or hopefully their body just kind of fights it. Eventually we got rifaximin, or I'm trying to remember what it is. It's an IV piggyback medication. They did find morphine kind of helped with just like dilation, and then proning them and having them cough a lot seemed to help a little bit. But in the beginning, there was like we were just giving them steroids, just kind of treating the symptoms, but not really the cause, and just seeing if they would progress well or just keep dialing up that oxygen. Whenever we kept dialing up the oxygen, we kind of knew. Once they got onto BiPAP, like each large device was kind of an extra nail in the coffin for a lot of these patients. And also just having them keep it on too, that was pretty scary as a new grad, just restraining people to keep the oxygen stuff on them.
You had to restrain people to keep it on?
Oh yeah.
They didn't want to keep it on?
Oh yeah, and sometimes we ran out of restraints and we'd have to like tape and stuff.
No. Yeah. Are you serious?
Yeah.
So you're literally like a COVID nurse survivor.
Yeah, I mean, it's
that's crazy.
And yeah, you don't, and with the restraint thing too, you don't do that without, like, that would be a situation where you would call the family if they're not able to decide or anything. You have to make sure that's a proper order, because that's where it feels awful to be a nurse, is like, impeding somebody like that when they're scared and need it to survive. Medical restraints is what they call them. But yeah, as far as the family members though, that was like the hardest thing, was talking to family who's just like yelling at you, and it's like, we're just here trying to help.
Why couldn't you call the family when they were calling you guys? Like, was there literally not enough time within those 12 hours to call?
Well, most of the time, yeah, like there would be entire shifts where you're just like, you get your meds and stuff in the morning, and then you're just kind of like gowned up. Okay. I remember feeling kind of smart because of evaporation. I was like sweating, and there are all the hand sanitizer things, and I'd like pump a bunch and like rub it all over myself, and I'd feel it like evaporate and get cooler. I'm like, oh. Go back in and do stuff.
So at that point you got promoted to days?
No, this was all nights still.
Oh, you were on days.
I wasn't on days until there was still COVID, but I went to day. Oh, it was like a little over a year. I feel like I went to days. Let's see, yeah, because I was doing my BSN at the time too, and so this actually for us now. I'm thinking about it a little backwards. It was the end of 2020 is when COVID like really was hitting. Now that I'm thinking about it, for us here, because in 2019 we were hearing about it but not really seeing it too much. And I was in my BSN program for I was in the collaborative one, where it's part of Questa, so you just finish it a year after concurrent classes and things.
The Monterey?
Yeah.
Okay.
So graduated, and that was great. I was with a group of other new grad night nurses, and we were taking classes together and being tired and able to like vent and complain about, just as you do as like a new nurse working nights and trying to figure it out. And then our class had to switch completely to online, and our clinicals had to completely stop, and we had to find alternative ways to get that done, which is a whole separate thing.
Because that part was after you graduated. When you graduated Questa College,
yes,
everything was still normal.
Yes. Okay. When I graduated Questa, everything was normal. And while, like, pretty much after I was done with my new grad residency thing, a new grad program, and was like towards the end of the BSN there was when COVID really started ramping up in our area, and all that stuff happened. It was, and it's crazy too, because I hear about stories from like New York and stuff, and like those places had it gnarly. We were mostly in ratio. Like I never went to 6 patients. I would have 5 tele patients occasionally, but like we were able to keep that part pretty under control. And I remember some of the more senior nurses were just like so amazing and nice, and they saw how bad we were struggling and would come and help us out, and were very reassuring and just like, it's never been this bad, like don't give up. And I'm glad I didn't, because honestly at that time I was like 100%, I was like, wow, I made a career mistake, like should have gone engineering. This is awful.
You thought that?
This is 100%. I was just like, this is the worst thing ever. And
were they paying you guys well, overtime, bonuses?
You could pick up as many shifts as you wanted.
Okay. They were there.
They were there. I would rarely pick up. I was doing school at the time too, and was just like, I need my time away from the hospital. It was brutal, and it was definitely telling too. One day I did have a day off, and I went mountain biking with a friend, and like ate it, broke my hand, ripped up my face, got stitches. Yeah, I got like
Jesus,
these guys here.
Gnarly.
And
on your day off.
My whole experience, I was honestly stoked and would like do it again in a heartbeat. I was like, I had 2 paid weeks off of work, and I was like, I need to live more dangerously. Like, dude, this is so much better and less painful than like the daily work life.
Yeah.
Ugh. Yeah. It was, and then that was kind of telling. I was like, man, this is ridiculous. But luckily, eventually, with the whole COVID thing, it kind of took a slope down, and less and less of those patients. They tried to hire a bunch of travelers. The pay is definitely something to be salty about. There were some, one of my coworkers, her husband's a firefighter, and I guess a lot of the places that, treated COVID so acutely got like these big bonuses from the state, and the firefighters, they got their bonus, and the company like just spread it evenly among the employees. And I didn't see how much our company got, but there was no, other than our just hourly pay, if you picked up bonuses, like we just got I got less than I get now because I've gotten raises, but yeah, there was no bonus other than I think a couple years later they did give just anyone general straight to your paycheck from state of California or federal, I don't remember what one, it was like $500, which was sick. I appreciated that, but yeah, the whole COVID nursing thing was definitely sucky as a new grad, but coming out of it is really nice. I mean, it's really cool to like feel more comfortable in my practice, and it just be genuinely so much easier, and people being in better moods too. There's also just like, I feel like right after that, like a dead zone just in out. Like nurses were just burnt out, really jaded, not nice to the patients and families. I mean, they still would try to be, but after a traumatic event like that, a lot of us were just like, it was really hard to go to work, and didn't really matter how much they were offering. Bonuses went as high as $850 plus your extra $100, so an extra like $950 plus time and a half to show up, and people were still like you can't make me go in there. It was brutal. Yeah, I mean, people were picking it up when it got that high. They would, for sure, especially the more senior nurses who were like, they can put up that wall. But when you're new, and definitely the students, I see it a lot, it's like patients have like a real emotional impact on you, and you genuinely care a lot, and that's awesome. And to function through a event like that, it's so much easier if you're able to put up like a good like professional wall, essentially, where you're doing your job, you're still acting empathetic, but you have that barrier to where you're still protecting yourself, versus as a new grad I wasn't really protecting myself from what was going on, and it was just like, it was a lot. And yeah, going out of it was just really refreshing. Going to day shift was when it started slowing down too. That was nice. I mean, day shift was, a lot of it too was, I'm not a great sleeper in general, so to have to like have my schedule flipped, and doing the BSN program too, we would have every other Thursday like 8 a.m. to 5 p.m. in class thing, so to like flip your nights to days.
Gnarly.
Every once in a while for a bunch of class was also, and I also had clinicals during the day.
Were you seeing a lot of the patients like dying?
Not me personally. I did whenever they get to comfort care on my COVID unit, yes, but the family would have to make that decision, or they would. But as far as like a traumatic death, not so much. If they were like really fighting it, and families like, no, go, they would eventually progress to vents on like ICU floor.
Did they have room for the patients?
I don't think we ever ran out of vents at our facility, so we were really fortunate. We never ran out of vents, never ran out of PPE. It was more so just the staffing situation of, imagine an entire extra unit that no one hired for, that's just pulling all the resources. And yeah, it made the other units like really unbearable, because they tried to keep because the COVID ones were the most like, oh, we don't even really know what's going on, so they would try to actually keep your ratio a little better there.
Yeah.
But yeah, it was. And then also the other thing is they just put a lot of pressure on the nurses, at least at my facility. They tried to really limit exposure to the COVID patients, so like only the nurse would go in there. They were having the nurses do all of the lab draws and everything as well, like the morning labs, which I was cool with, because I'm like, oh, this is my comfort zone. That was my favorite time. I'm like, yes, morning labs, this is what I know how to do. Confidently go in there and get it.
Start an IV, or no, just poking with a needle?
Just poking with a needle, seeing what labs are ordered, what labs they need. And a lot of the nurses, they don't regularly do that at my facility, so there were some pretty funny mishaps. One of my coworkers did they didn't realize they're vacutainer tubes, and is used to like pushing down on the plunger. So she did that and just exploded a blood bomb basically in the room. Because if you just like keep putting pressure on it, it'll pop open.
Yeah.
It does it on its own with the vacutainer.
So it's just blood mist everywhere.
More just like a big splat. Like the whole thing just blew open. It was just like, luckily PPE and everything, but just if you took a 10 cc little small amount of blood and just threw it in the room, that's kind of what happened. But we had to do a bunch of extra rolls to like limit contact with the patients, and it was just a lot of pressure activity on the nurses. And I mean, ultimately I think we did a pretty good job of limiting exposure, and the unit was, despite it being like scary and awful psychologically for the patients, it was infection control wise like a pretty good spot. So yeah, it was definitely interesting going through that whole COVID I apologize. I feel like I'm all over the place
No.
my story. It's just like
we're
man.
flowing right now.
Okay,
like,
cool.
You're in flow mode. I'm like, I have a queue of questions.
Oh, cool,
like,
cool.
I'm literally just like waiting for my moments and stuff.
Sweet. Yeah. I mean, it's weird recalling. I don't talk about it much. Honestly.
I just thought it was interesting.
Mm-hmm.
I definitely like wanted to ask you questions based on COVID, literally just from that one day when we were at Sierra Vista.
Yeah.
Not this week, not the week before.
Yeah.
But the week before. Maybe it wasn't the week before.
No, I remember you asking some questions about COVID, and we talked about it, and then I was walking away. We both had a lot of time.
Yeah. Like that was that must have been the slowest 2 days on step down I've experienced, because I remember me and you chatted on and off that entire day.
Yeah.
For like definitely a while.
Oh yeah.
But like not like this past week, I feel like I didn't even like see you.
This week, yeah. I mean, that's the nature of it too.
You know what I mean?
It's just like totally. Yeah, that was cool. I remember walking away from that being like, oh man, I haven't thought about that or talked about that in a while. But it's it's good to readdress and kind of being like, okay, yeah, we got through that. That's good. It's the whole pandemic thing. I hope it doesn't happen again, but we'll see.
Knock on wood.
Yeah, definitely. It was a rough way to start for sure. Definitely grateful to my senior nurse faculty and some of the leadership people who would come in extra and just were encouraging that. Telling me like, don't worry, it gets better, and this is the worst it's been, because hearing that made a big difference, because the idea of it being like that indefinitely was just too much. But at the same time, there's a thing in healthcare and basically when you feel like there's a great need for something, it's really hard. And especially if you have like your friends working with you and stuff, it's really hard to like abandon that and not be helping the situation continue to do your part. It's what it feels like, which is also dangerous too if you're struggling super hard. And it's, just kind of unprecedented working conditions for me at the time. I mean, it was just such a different thing from being a phlebotomist and things like that. But
and then we're told like everybody left nursing during COVID, and now there's like a surplus of job opportunities. It sounds like, and we're like all guaranteed jobs upon graduation, and that's what it sounds like from everyone who's talked to us. It's like
it was. So that's a good point. And
you saw people quit.
Yes, but in the same facet of kind of what I was saying, where they don't quit during the craziness. Like, I've seen some stories of groups of ICU nurses in New York or places where it was like really bad, who like they get through it, and then like once it's mellowed down enough back to like some sort of normal manageable level, the whole group just quits, and they're like, all right, we did our job basically, and now we're retired, we're done. Like that was, so they want to have a good stopping point. I feel like most people, I didn't see anyone actually quit during COVID at our facility. We were all kind of just like, needs to be done. We're gonna kind of get through it. But there was a big slowdown. I remember students weren't allowed in the hospital at that point. So that was a whole issue where...
that sounds like a bad idea.
Yeah, so I feel like kind of why we were having problems and still have those hiring opportunities, at least at our facility, is we've never really caught up. I remember the first couple years after those students, their clinicals were just like, I remember one of the students telling me they did their Foley competency on Zoom with like a teddy bear and like a tin can, and they like mailed them the kit, and they were like, had a instructor observe them, like describe everything that was going on, do it correct as far as understanding and all the concepts associated, but doing it in a scenario like that. And very expectantly, these nurses got hired because we need people, and were just wildly unprepared and so scared of the hospital. They were showing up and I mean, you could tell that. I mean, I don't know if you've seen first-year students at the bedside or remember kind of what it was like when you're first interacting with patients in a hospital, but it's it's scary. You see them; they're very sick, they're very uncomfortable, and our natural intuition is to like care for them, be very or scared. There's a natural response to be fearful of things, that people that are sick, essentially.
Yeah.
And you just figure out how to adapt to that. So these graduates who are registered nurses are having to go into that environment, pass their tests and everything they need, but their clinical experience is not in hospital.
Social skills,
and
essentially.
They're it's just really hard, and it's also still pretty. It's not as bad as it was during COVID, but it's still tough. We have like less staff and everything, and they kind of show up, and I saw it on their faces that like I made a career error, like the same thing I thought. I saw it on their faces, and I was just like, man, that sucks, because at that point I was just kind of getting over myself and being like, oh, there's still a lot of value here. I got some like above and beyond award, which was really fun. And also just insights and realizing things I have about nursing. Because I got that award, not because I'm a good nurse at all. Like, I literally remember getting the person who got it was because I talked to this person about Pier 46. We talked about like eating fish and stuff and like different foods and being like, oh, that's so exciting. And I just did the normal, like helped her to the restroom and back. Nothing spectacular. They were like a post-op hip patient. And she was like, oh, that's one guy, he was so awesome, so caring. It's like, we just talked about fish, So patients, they really see things through a different lens. Anyways, let's see. Got off on a side tangent there. Back to the students. The new students at the time were just, that group, a lot of them showed up and were just like, I want to say they're still in nursing. I've seen a handful of them doing things like home health and other like out of acute care hospital setting, and doing pretty good with it. But it really just like pushed a lot of people of that class out of the hospital setting. There's still a few, but that just kind of went on. And then the lack of staffing, I feel like nurses were just kind of more jaded and honest with the students would come in. Then I would see the next kind of group. Students would come in and nurses would just be like, run, basically. They were just, the students could tell the nurses were just very unhappy. This was maybe not a job they want to do. I think the students still went through and like completed the program, but we're just not, it wasn't really as nurturing as an environment as like I experienced when I was a student in new grad. And I think just like I feel like your class, do you feel like nurses were pretty encouraging, receptive? I feel like I'm finally seeing that again.
Yeah.
Like from when you were a first year is my thought.
Yeah, I've definitely have worked with people that don't want, like, I can tell they don't want to do their job. And it's like, dude, like
yeah, the bare minimum.
Like you gotta like,
yeah,
if you're gonna do, I don't know, like nobody wants some, like when you're sick in the hospital, you don't want some like nurse that's in a bad mood. Like, I don't know, like I've just seen it multiple times now, and I'm like, okay, like this is now interrupting my day because they don't want to work with me, they don't want to teach me, they don't want to like be anywhere near their patient. Like they're just kind of doing it for a paycheck, and it's like, all right, like whatever. But like I feel like this profession in particular, it's like, I don't know, I feel like you have to have some level of chillness where you're like, all right, like for sure, like I'm down to take care of you and like listen to you and like get you what you need and just like, talk to you. And it doesn't have to be some like okay, this week in particular, and I forgot to tell you because I know we're supposed to like text you like the good things you're doing and stuff.
Worries, that's good.
But like for example, this one lady in this week was cool. Like both people I worked with were super sick. It was more like, and then I was like, hey, like what's your pain level when I did my morning vital signs? And she's like, oh yeah, like super severe chronic pain. And I was like, okay, like they gave you the hydrocodone, the Norco or whatever. that should be kicking in literally right about now. And she's like, hey, like, I've been addicted to heroin the last, like, X amount of years. Like, that's not going to hit me. And then she said I was, like, the first person that's taken care of her that's been like, okay, like, that, like, like, that's probably right. Like, it's my job to advocate for you and let's get you the stronger thing. And then she was like, oh my God, like, thank you for listening to me. So then I went and told the nurse, and then the nurse gave her the IV stuff. And granted, like, she was like, yeah, I didn't even feel the Dilaudid or whatever. But
still, like, yeah, it didn't really
she was like, dude, like
dude, that effort. You. Yeah,
thank
exactly.
You.
The fact that you are, you know, listening to what she's saying and trying to actually help and do treatment is awesome. I mean, they're very receptive to just you as a person and how you're communicating with them, and that's awesome. I mean, that's one of the things I love about nursing, is just that you can treat people like that. It doesn't matter if they did a ton of heroin, whatever it is. It's like your job is to advocate for them and their health, and part of that is the more medical side of things, what the doctors are going for, and, you know, explaining that whole process, helping them be stable in that situation. But it's also just being emotional support for them. And when you hear what they're saying and being able to translate that and show them that you're going to give them a medication. Obviously, there's situations where there's drug-seeking behavior and things like that, but, you know, most of the time, that's also a pretty intuitive thing. You can kind of see where they're at, and you'll see nurses just kind of stereotype patients. That's something, unfortunately, I feel like as you get more experience, you do, just for the decrease of mental stress, as you kind of have these categories of what you expect to see with certain patients, which is so valuable about having students and new nurses on the floor. They're very detailed in their assessments, maybe doing extra things, but they're catching extra things too. And it's awesome. That's the thing that I like having, is, you know, these last couple of years too, seeing students and new grads kind of coming in. It's nice having kind of more eager, excited people in the workplace too. It definitely makes a difference.
And then this week, when we saw you on Monday, you were like, hey, like, the last couple days, work's been slammed.
Yeah.
And I remember you said something, it might have been the first day, it might have been the second day, but I remember you said something that, like, caught my ear, and I was like, I gotta ask you this in the podcast. But you were like, yeah, the person who was you were like, one of my 3 patients that you had this past weekend, one of them was super sick, and I pretty much had to be with them the entire time.
Yes.
And you were like, yeah, like, I guess for you were like, yeah, like, being with them to make sure they got the level of care that they needed in that exact moment, part of time, it was like, you might be the person saving their life. You know what I mean? Like, what was that situation like? What did they need? Why were they so sick?
Yeah, so that patient was an alcohol withdrawal patient going into their 3rd day without alcohol. Normally drank a liter of tequila, I believe, a day. So 3rd day is when they tend to experience the severe withdrawals. And they will be HIPAA compliant to and only say the medical things. They were also Spanish speaking only, so there's a little bit of a language barrier there. Luckily, there was some family that would be in and out, so they were very helpful. But basically, initial workup only got that it was going to be a withdrawal situation, and so that's what we were treating. We were just kind of doing our CWA protocol, giving him benzodiazepines to suppress the central nervous system as it went up with the withdrawals, essentially. And so he started withdrawing expectantly, shaking, convulsing. Usually you'll see, like, heart rate go up, and that's, you know, due to the stress. So then you can normally keep them pretty stable, maybe have to get them on BiPAP depending on how they're breathing and other complications. But basically, I was just treating the withdrawals, which is manageable with the other 3 patients. The other one was a hepatic encephalopathy, also memory care dementia patient. So they just needed lactulose, but their ammonia was too high, didn't have a swallow, so they needed to have the enemas for that. And also weren't appropriate for NG tube, would have pulled it out or needed restraints. And then the third one was, what was the third one that week? He was pretty okay. He was something cardiac related. I'm not remembering that one. That one was much more stable. But the one I was stuck with, basically they started breathing respirations up in the 40s with like audible expiratory wheezes just at the bedside. And then their level of consciousness went, they were always confused because of the withdrawals, just saying kind of nonsense. Knew their name, but didn't know where they were. But respirations went up, blood pressure tanked down 80s, and they started developing a fever. So, I mean, if you do your sepsis screen, it's like, okay, this person looks like they're going septic right now. So basically we had to get sepsis protocol going on this patient and try to get them back stable so that they didn't just keep decompensating. We had to do ABGs to make sure those respirations weren't putting them into like a respiratory alkalosis or anything from breathing too fast. Eventually they'll start tiring out and breathing slower, and then that's when we would like put them on a BiPAP to blow off the CO2. But basically the whole day was just watching him go through these withdrawals and giving him lots of Ativan, 4 milligrams every 15 minutes if the CWAH was over 20, which it was, until he stopped shaking. So yeah, at first I thought it was just withdrawals before the blood pressure really started going off and the temp continued to climb, because sometimes they get like sweaty, part of withdrawal symptoms. But basically I was just with this guy and, didn't want him to actually go into a full seizure with the withdrawals part of it, but then began to notice that, he's getting septic and we don't have any antibiotics or anything on board. So we ended up hanging 3 different antibiotics and fluconazole in case it was like a valley fever. And also giving him albumin to replace that, because his liver's not doing great as an alcoholic. And that improved the pressures slightly. By the end of the shift, we got him up to, I think it was 100, like just barely. That was stable. His temp came down from, it was like 102 down to like 100. And oxygen, we had him on like a 5-liter oxymask, and I think we just kind of kept him on that, but that was getting worse. I'm pretty sure he was also getting a little bit fluid overload, like he had some undiagnosed CHF. Could have also been contributing to his breathing issues, because that wasn't improving with anything that we were doing. So that's my anticipation, and they probably would then just do like that BNP to see like where that's at. But basically it's this dude who just didn't have medical history because he hadn't been seeing the doctor, going to the hospital, and then came in for withdrawals, and we just started discovering all this extra stuff as the shift went on. And if at any point he like really decompensated and needed to be intubated, we would have just moved him over to the ICU. But he was just kind of in this in-between critical space of management, and I don't know, I've just had patients sometimes pass during situations like that, and knowing the other 2 are still critical, but I'm able to kind of pop in there, do the treatment, see that the hepatic encephalopathy patient was making improvement. They were going from like originally they would not open their eyes, only to like pain would they open their eyes. They would only make incomprehensible words. They would just screaming, which was really sad and unfortunate. But by the end of that shift, I had her or 2 days, she was screaming, "Fuck you," and like, God, like, that kind of stuff, which is an improvement. She's saying words now, And then by the next day, her ammonia dropped from like 220 to 90, which isn't even that crazy of an ammonia. And she was able to be kind of like, "Oh, where am I?"
Whoa.
And
that's scary to think about.
Yeah. So it makes a difference. She was still, her mouth was, that one was also an issue. I mean, she was having swallowing difficulties, which is why we were giving it via enema. But when we went to do like clean her mouth out, we do like the suction and everything, and her mouth was just not taken care of. We put the suction in there, and her tooth literally just like cracked and fell off. Whoa. And then there was just blood and pus, just
Jesus.
And we cleaned it all up, got the bleeding to stop and everything. But yeah, she likely had some sort of infection going on in her mouth and needs something there, outpatient follow-up. But yeah, her situation also wasn't great.
And you said the doctor was kind of like not around when you needed them to be?
Yeah, unfortunately. Yeah, the first day they didn't get there till much later. They were busy, I think, on med surg or something. And the second day they did come first thing in the morning, which was really nice. We kind of got things started. But yeah, I mean, different doctors have different styles. Some are much more in person. Others are, more phone calls via the messaging service. All of it, everyone's a person, so people have different styles in the way they handle things, Yeah. And, they were, kind of, I realized I was talking to my charge nurse, and they, we're encouraged to do SBAR style report, and that ends with the R recommendation. So I give my recommendation, and certain doctors, they're very intelligent. They went to med school. They know all this stuff. And I don't know how much they understand of the nursing role, but they take the recommendation as if I'm like trying to, control the medical care. And I'm like, really, I'm just like, this is just what I think. And I'm trying to help the process along. And some of them will be like, "Oh, no, I want to correct, do this other thing." And then you see them put in orders and it's like what you asked for. And you're just like, okay, whatever, that's fine. Or they just like, they really want to look into it. They do know more about it and have the time. I have a pretty good analogy of kind of how I feel like the process goes is just like, I played water polo growing up and stuff. And, it's so different being in the water, like playing the sport and having the awareness of like where to pass the ball, what's going on under the water, all this stuff. And you're getting splashed in the face and stuff all the time. It's hard to like even see what's going on. And you still have to make these decisions versus your coach or somebody who's observing from the stands. They're like, there to there, like, why don't you see it? Like, organize this better. Yeah. So it's like the kind of, from different perspectives or from hindsight, it's easier to, reflect over and like come to better decisions, which is why I think it is important that they have the time to like pore over the data and make the decisions and things.
I wonder what you look like while all of this is going on, because you only see what we look like when we're in the student role taking care of our patients and we come to you with questions and stuff. Like, I wonder,
that's a good question.
I would be so down to just like watch you work a shift, but that's not possible.
No, you can. I mean, they actually allow, you have to like go through HR and everything and get signed. But yeah, we could like sometimes they'll even have high schoolers come in and shadow like PT nurses. Yeah, just to kind of like, oh, we want to see what you do kind of thing. And it's pretty fun. I remember doing it as a phlebotomist and almost making a student pass out, because you're drawing blood, and if they're not ready for it and their knees are locked, they can get all woozy. But yeah, it is cool. That's a sick thing about preceptorship too. I have a couple of you guys that'll be working with me. But yeah, definitely. I like to, my main thing is just encouraging students to kind of find their own flow, and just like pass on the little tricks and tips that I've picked up on my practice, because nurses, they practice very differently, and as an instructor it's cool to see that, because once you're on your own, you kind of develop in your own way. There's really way less supervision than I was expecting when I first started. It was kind of like, okay, yeah, now that you're done, it's kind of on you to ask questions to your charge nurse, to your peers and stuff like that, because you'll get your chart audited and things like that. But I mean, really, the doctor's going to come and look at your patient, the next shift's going to look at your patient, but they're not going to look to the level of how we do in nursing school, where we're watching you and making sure, okay, they're doing these skills right, they're doing good assessments, they're picking up these things. But yeah, as far as my process goes, it's been cool. Being a educator has been awesome too, because I get to like keep adding to it. I constantly see things students and other nurses are doing that I'm like, oh, I'm gonna do that now. That's a cool way to do this.
Audrey said it the best. She was like, because this is, I think, for sure my first time having you as an instructor. Mm-hmm. I want to say it's her first time too. Yeah. But we were talking about like your methodology of teaching is so different than everybody else's.
I'm sure it's very different. And I'm like, dude,
like, I don't know. I can't put my finger on it, but Eli does this thing with technology and I like can't put my finger on it yet. And then Audrey was like, yeah, like what he does is he maximizes functionality of technology. Because you were showing us shit we've never even heard of before. Like, you're like, yeah, you can queue up all the meds in the Omnicell, and like you do this with the IV, and then you do this, and then I'll show you this trick for flushing, and then how we can transport it from the vial into the syringe, and like when you're going from the vial and it's like the powder scraped around the ceiling of the vial, you can kind of square it. Like you were showing it like for like, you were
I nerd out on devices and things. Yeah,
but like we need that to know how to do it efficiently. Because I've worked in a restaurant for so long that like I call it a hacking. Like I've done this thing for X amount of years and I'm so used to it, and then someone else will do it like a little bit better, and I'm like, I call it hacking. I'm like, okay, like you hacked the system because I thought I had it figured out, but I'm a dumbass. You have it figured out. And I'm not saying like I'm a student in nurse. I'm saying in like a restaurant where I'm way more comfortable and I can like
the stuff,
do it with my eyes closed essentially. Like I'll see something and I'm like, okay, like you're hacking the system. You just sped something up a certain amount, and like now I'm going to adopt that pathway and teach it to other people who got hacked out. You do that same exact thing with us. You're constantly like, I don't know, and that's why I'm stoked you came on here, just to like just so we can kind of see that side of your brain.
I could definitely go into that. So that is 100% my upbringing. My dad and engineering side of the family, they are like, I mean, you should see the stuff that they do. Our sprinkler system at the house is, like at my dad's place, is, I don't know, make gnarly stuff. My brother one time, him and my Uncle Mark for 4th of July, they do all this like really intense radio frequency stuff, and he built this like helix antenna that he was able to like time when the NATO satellite came over and get it to show us images of fireworks going off from above, like from the satellite during the 4th of July. He just does like, they do like really gnarly technological things. Yeah. And I like it. I like devices and kind of really figuring out how they work. I took a handful of physics, mechatronics, electronics classes. Like in high school, I was kind of going into the engineering pathway. I did like the Endeavor program, design engineering and stuff. We had some cool projects, and just that like brain and way of thinking is way different than nursing. Yeah. But I took bio because I needed to have a life science my senior year, and I was like, wow, this is so cool. I like it so much, and it kind of like changed a lot of things for me. But yeah, being interested in how things work and making things efficient. Like in the video games I play, I like to play strategy games where you like kind of mess around with things on like a turn-based situation where you can really just maximize efficiency, I find really satisfying.
Or if you lose, at one point along the path of your decision making, you made a mistake.
Oh yeah, and I'll even go as far as like I make multiple save points kind of thing, and I'm like, I see that something could have been done better, and I didn't even lose. I'm just like, and let's go back here and like do it a little differently here. Yes, the outcome was better. And med-surg was such a struggle for me because of how many things are going on at once. The kind of multitasking organizational thing was really hard for me. But as far as like looking at different fields and systems and finding ways to better explain, better utilize technology, I mean, really just, I feel like the main thing is I understand and respect the amount of, I don't understand, that's definitely an overstatement, but I respect and want to utilize people who do things like coding, engineering, design, even like text, people like putting things together, like the amount of effort it takes to make something as simple as like one of the wall works for your phone. Like there's actually a lot of technology in those little cubes just to like, we don't even think about it. We're just trying to jam a USB in it and like get it to go to our phone, but it's actually doing a lot there. And the people who design these things put in so much thought and effort into something that we think is very simple, and taking the time to kind of understand and realize what was the person designing this intending, what are all of the things that we could actually do with this. And a lot of times it's like we're just kind of expected to use some sort of system, and with Cerner it's like the user interface is just frankly not user friendly. It's in my mind I think of like the Apple to Android, where they're both great products, and Apple just has, people tend to like the user interface more. It's a little more intuitive.
But Android, you can do more if you know what you're doing.
Exactly. Okay. Yeah, it's a little more open for people. So, I feel like Cerner's got that kind of Android Microsoft thing where it's like it's actually pretty functional once you really understand all the parts, and also whatever version of it you got to. People buy different different packages. I think of it like Microsoft Office. You have like the basic one, and then like the different suites with more programs and things. And different hospitals will buy different systems. One thing we were irritated about at our hospital was they didn't opt for the global search. We used to have like a global search on our medication machines, and you go to PulMed, it's not there. You could find, okay, well, where is it? And now they didn't pay for the extra thing to let us do that. So it's like an Easter egg hunt every med pass, especially on med-surg where there's like 5 Omnicells.
That's not okay.
And you're running around just like, oh my gosh, where is this?
That's not okay.
So I talked to pharmacy and figured out it actually on that Omnicell tab where you pull your meds, that will tell you where they're at. And you can hover over it and it'll give you the list of locations. So it requires a little pre-thought, but I mean, that's been a huge thing for me learning these, like those tips and tricks talking about is I love networking, and I'm real into just the interdisciplinary teamwork, like hearing other people's, oh, this is how you should do it, this is how this works, and kind of having an understanding of what everyone else does. And with the devices and things, I mean, I just remember in the beginning it all being kind of like magic, like setting up an IV piggyback and you're programming the pump and you're like, okay, it's working, it's dripping, but not really grasping what's going on. And now I'm very comfortable. I mean, I can do it pump free, and I like to explain what's going on. And okay, see, here's a back valve here. Nothing's going to flow this direction. When I put this below the flush bag, it's going to fill up. I can confidently prime a line holding it at the level of the flush bag and just be like, it's not going to overfill. It's just going to create a loop, and then I close it off, It's like just understanding the technology you're using.
It'll stop if you hold it with the flush bag, but if you lower it down, it'll fill all the way up.
If you lower it down, it'll like fill out. That's how you usually prime it, is you go with your thumb on the roller clamp and you just let it flow, and then you stop it right at the end. Mm-hmm. But if you're holding it above where the flush bag is, the fluid's gonna, it's like a big U. If you had a giant tube full of water like this and you held it like this, it would just be full of water. So basically, if you hold it above the flush bag, it's going to fill until here. And then you just go down a little bit. Boop, it's done. Clip.
All right.
You can do that.
You taught me another thing because I kind of bend down a little bit.
Yeah, I know. Everyone's like, they're back. They're like, oh, what's going on here? And, you know, it's, there's a lot you can do with the tubing. That's pretty fun. Yeah. And then also just like the programming of the pump and things like that. There's all sorts of stuff with devices that's like, I like devices. That's something I want to get more into, actually. I've been wanting to get like line certified to do picks and things.
Gnarly.
I think would be sick.
Yeah.
But yeah, that's a like 1 day thing. Right now I'm like, you know, doing the education route, and that's been, I don't know, I just enjoy it so much. I mean, I especially after I worked those 3 days at the hospital, love my coworkers and stuff, and it is a rewarding job, but to wake up the next morning and it's earlier, so I was definitely more tired, but I'm like I'm cool to go here. I'm excited to do this, and be around students that are excited, like, you know, hearing about your interaction with the patient on the methadone. Like, that's awesome. I love hearing those stories. It really helps remind me like why I went into nursing, like, and just having that genuine caring feeling towards people and having that be like your career is just awesome. You know, it's really a blessing to be able to have such like a human instinctual thing as a career, essentially.
True.
To be able to like care for and talk to people and, you know, try and improve their health.
Yeah.
It's definitely difficult with like the type of population we see, as, you know, I'm sure you've kind of experienced just the type of patients you see in the hospital are like, it's tough. But, you know, it's also really rewarding. It's cool to do stuff for them. Back when we did, because you guys don't do care plans anymore, we just do discharge planning, which is quite wild. I mean, care plans were such a thing for nursing school and still are in a lot of programs, but they've really, you know, now they're like on the computer as like the goals, the interventions. You've seen the care plans that we have in Sterner. Yeah, that used to be a whole significant portion of those packets, just like papers that you would write on care plans. And it's basically
just how to take care of somebody.
They're called NANDAs, like nursing diagnosis.
Yeah.
And there's a whole book of nursing diagnosis and, you know, what you do about them. And it's kind of like, you know, they have their medical diagnosis and why they're in the hospital, and then we would, in conjunction with that, create nursing diagnosis that go along. And nowadays, basically, they automatically suggest nursing diagnosis based on their history and current diagnosis of things you can do to help them within your scope without doctor's orders, essentially. Okay. So they are actually, like, if you have the time, nursing diagnosis are awesome, and they'll can really improve your patient's health and everything. The issue is we rarely have, I mean, you see how strapped we are just to implement the regular medical orders, you know?
Yeah.
So it's unfortunate that they're not as utilized as they could be, you know? I feel like the healthcare system is, we just work really hard to kind of get people just well enough to leave the hospital, essentially.
Yeah.
And they do try to do things to prevent that. There are rules that if they come, like, legitimately have to be admitted again within the month, that, like, it's going to be basically we're covering their stay at that point. We didn't do our due diligence of getting them well enough or having them follow up outpatients. So that's a whole issue too. Yeah, the whole system is pretty overwhelming. That's kind of being in my master's program right now, just learning about managing complex healthcare systems, and like these different advanced practice classes are kind of eye-opening a little bit. I've never wanted to be in like management, so that's not like my route, but it's definitely gives me more respect for what they're doing, and stuff that I personally just like wouldn't want to deal with. I had to create like a market analysis and all these things. I'm like, man, I like being at the bedside, working with patients, working with students, and the leadership stuff. As far as my style as a teacher goes too, I mean, that's kind of a fun thing, because I didn't go to school to be an educator at all. I've worked my whole life in different jobs and done sports, been basically I coached water polo for a season at the high school, but it's kind of this coaching thing. I did a good amount of early childhood education classes, like how to educate kids. So I don't know if you've noticed some of my techniques from that, but
I have not noticed.
You haven't?
No.
The stickers.
Oh my gosh. Oh shit.
Right?
Okay.
Yeah, it's all
I thought you were doing that just because they were cool stickers.
Well, that too. But
okay. Whoa. Okay, my mind's blown now.
Yeah. So
that's your child technique?
Yeah, you give them like little rewards,
Okay.
It's like, you did good, like you get a sticker. Like that one's a little more like in the realm of creating like a team and kind of a bond. If you have like a little bit of like a mascot or team type situation, you have like a higher sense of accountability and things like that. You feel like you're part of the group. You can perform better. There's just a lot of things I take from non-traditional, like, I'm just about to do my year of like the education portion of my MSN education. I'm just completing the core component right now. So I'm excited to learn what I'm like supposed to be doing, because so far it's all just been like work and life experience based. And when I was a swimmer, I coached a lot of swim lessons and things like that, and I love teaching like technique and things like that, and getting really just into detail with physical movements and analyzing how people are doing things. It's kind of funny because I feel like I could teach someone swimming technique better than I could teach nursing. I'm getting better at nursing as time goes on, but I mean, my main thing I feel like is that I try to be very approachable and understanding. I'm a recent graduate enough, it keeps getting farther away, but where I really empathize and respect where you guys are at as students. Like I commend you for like what you're doing, and I want you to feel like there's no stupid questions. I totally remember teachers saying things and me being like, trying not to feel dumb and being like, oh yeah, like that makes sense, or not understanding an acronym. And also just being humbled and open to like, oh yeah, I didn't know that, or oh, things change all the time too. Some of the stuff I learned is now a different, they've done new research and best practice is different. A lot of nurses aren't necessarily keeping up with like best practice and reading the current journals and everything. It's technically that should be on the leadership, like the CNO, updating policies and things like that. But for me, it's been great because I'm getting to like relearn and solidify a lot of things with you guys, and then just kind of, my going into this, my big goal as a teacher, because I felt pretty underqualified and just like, oh, you just need people. But I mean, I'm happy to do it and I'll definitely help. So my goal was basically, and still is, to decrease that feeling I had of just like I made a career choice, like this is really hard, and kind of bridge the gap of what we're doing in nursing school to how we're actually practicing, and bring them closer together. Because nursing school, like gold standards, awesome, like let's get more of that back. Like some of the stuff can be a little bit of sloppy in practice, and then also realizing that this is the expectation at the hospitals right now, and let's find ways to it be still within our policy, still within like a best practice kind of situation, but that it's going to be more efficient, more realistic. Let me help you, encourage you to do things that I struggled with, like delegate, It's really hard as a student nurse, especially a new grad, to tell someone, hey, can you help me out with this thing? Can you do this thing? So being a model in the sense of, I tell you guys, like, hey, delegate to me while I'm, watching you do your med pass. If you're needing to give like a Colace to these meds, you can explain it to me outside the room, and then tell me to do the vital signs while you're just to kind of,
speed things up,
keep your flow going, encourage you guys, and understand that, at some point you will have access. You won't have to wait on us. It's going to help your flow a little bit. But, just keeping that light, essentially, because that's just going to really pull through for you if you will, and there are hard shifts, but that you want to just keep improving, keep working through things. I feel like I lost my train of thought there.
No, you're good. You're good.
Working on
you have to go soon, right? It's 7:40.
Oh wow.
Time goes fast when you're
it does.
Camera,
wow.
Yeah.
I had no idea. Oh, my buddy hasn't texted me yet. I mean, he's chilling. If you had any other questions, I'll try to just be a little quicker
here.
on them.
Can I take a piss break really fast?
Oh, of course.
Okay. Do you need to go to the bathroom or anything?
I don't, but I could grab a little more water. Would be
Yeah.
All right.
We'll do a quick pause, and then once we come back, we need to get you out of here. You got taco night.
Taco night. Yes.
Last question.
All right. Cool.
Or maybe last. Yeah, I'll make it fast.
No worries.
So you might be like moving to a different part of the country.
Yeah.
And I think everyone's gonna miss you, right?
Yeah. Man, that's such a.
And that's like soonish, right?
It wouldn't be until at the soonest next year, next like fall at the soonest.
Okay.
So over a year.
What inspired the decision? What are you gonna miss here? And like, what are you looking forward to?
Okay. Yeah. So inspired the decision. My girlfriend, partner, she has like a really good job opportunity over in Jackson Hole, Wyoming. And it's, from what I hear, like one of the most beautiful places on the earth over there. It's got awesome snowboarding, which is my favorite activity. It's expensive, but one good thing as a nurse is you get discounts on that kind of stuff. I think I've told you guys that, yeah. So you can get an Icon Pass for almost half the price, so worth it. Those are kind of the personal things for me, but really what's driving it is that my partner has that really good opportunity over there, and if we're going to start a family and everything, having good income is going to be important. So she's receptive to other places as well. She's a physician in residency who has a lot of debt from medical school and everything, and from what we're seeing in California versus other states, there's much more need in the more rural areas, and she can pull in a lot more essentially and overcome the debt stuff. Her parents immigrated over and worked pretty normal jobs, so they're also like, basically their plan was investing in her to help with like retirement and things like that too. So she has kind of a very big plan set up, and her family and her, they're awesome. They're like the most wonderful people, and I want to be a part of that. As far as the area here, it's definitely a hard thing for me. Like I've literally been like scheduling appointments to like kind of make sure I'm processing it well and that I want to do, because originally I did definitely foresee like, yep, I was literally born at Twin Cities Hospital and I work there, so
gnarly.
Yeah, the community
You're
I've
local.
got here. Yes.
You went to Templeton or Paso?
Paso High.
Okay,
yeah.
gotcha.
So yeah, it's very like first degree of separation. I mean, I'll either like know the person I'm talking to, or within talking to them know the one other person. It's, just being here my whole life, it's pretty wild. And I am the type of person too where I enjoy running into people in the grocery store and stuff. Yeah. And I'm just like, oh, what's up? Patients, nurses, whatever. So that's pretty cool. And yeah, that's definitely going to be something that I would miss a lot. Definitely plan on like flying back regularly. I would like, as far as the area for myself, they do have a community college over there and a nursing program, and how much I've loved working with Cuesta and that kind of stuff. I want to continue in my like kind of dream mode. I think about like, oh, like it's a sick snow area and stuff. I've thought about it for Cuesta too, having like some sort of they do the way Jasmine found out about that place is it's like the wilderness medicine like expert place. She did a emergency medicine rotation there, so having like opportunities for students to go to different, maybe more remote rural locations and practice nursing and see different things, and hopefully finding programs and funding for it. But when I was in school, we attended some nursing conferences and things, and it was really cool. So I'm hoping in the future to like set up wherever I'm at, like where you can go and see different hospitals, different states, the way they practice nursing. Maybe if you're able to go see like a flight nurse situation where they go pick up someone in a precarious situation. And
that sounds wild.
Yeah, exactly.
And you might be doing that over there?
Right now I'm talking to a outpatient clinic doing like PACU type stuff, and then they do have ICU and like a nice hospital there that I might be looking into. But I was thinking, as far as, because I love the whole like student classroom type stuff, and bridging that gap, so creating opportunities for students to be excited and kind of find what they like in nursing. That's a big thing for me too, is encouraging people to like see the different units and specialties and kind of decide like, oh, where am I kind of gravitating towards. So hopefully creating opportunities of travel, essentially, like, hey, you can get some clinical hours, and maybe it'll cost a little bit of money, or ideally it can be sponsored, and we get grab a group of people from California, go to Wyoming, people from Wyoming and California, do stuff like that would be really cool. And that's just the whole networking thing. But I definitely have strong roots here and love it. So, I plan on being back a lot. And as far as, establishing community there, it's a very small population. I looked it up, and the entire state of Wyoming is like 500,000 something, which is like, you double the population of SLO County, and it's more than the state of Wyoming. It's
gnarly.
Pretty crazy to think about that. Yeah.
Wild.
Totally.
But it sounds like you have an opportunity to go try a change, and if you don't like the change, I feel like you can always move back. Is that how those things work? Yeah, so it's definitely, and I've never moved out of the area. Yeah, I've always been in this county. I'll, vacationed other places and whatnot, but I've never lived outside of SLO County, and everywhere else I just travel to. So yeah, it's been cool. My best friend, he works in wine, so I was checking your wine label and everything, because we go, and he's a member at a handful of wine clubs as industry, so we go and have a good time enjoying local wines and seeing the similarities there. One of my lab scientist coworkers left lab science to go work in wine, and then came back because it was like actually really gnarly. So it's really cool to see, just like the similarities sometimes in different industries, that you could cross-train from like a human medical lab science and then go and do like wine lab science. Yeah. That's pretty gnarly. And people get like snobby up in the building about their wine. They are
so, yeah.
You're into wine. You are the wine. The way you touch the bottle, you're like, hold on, like, let me, before I ingest this. And that's just like, that's probably wine you would never drink, because it's just like a cheap bottle. You're probably drinking some bougie shit.
Yes, but it is good, and I appreciate it. And the bougie shit.
This is student wine.
Only because it's, we get like the industry discount / the crazy thing about wineries, a lot of them, they're trying to pour their best bottle for their, people that are buying wine, and they'll have these hundreds of dollar bottles of wine all open, and they want them to taste their best. So whatever's not poured at the end of the day, employees take home. And that's my buddy who I hang out with all the time. So it's table wine. It's like his table wine is $100 bottles of wine that are awesome. So yeah, just like different perks of the area, essentially, knowing people who work in the industry, and that industry is really fun too, where a lot of people are, they kind of work together and collaborate to make different blends and things. They'll talk to each other, and it's really impressive, the kind of stuff that they come up with. And you'll get people from France and coming over and growing and doing stuff here, because it's less basically regulated there. They have their, like, this is how we grow wine in this area, and you have to do it this way. And here they're a little more experimental, and also the Paso vibe's just a little more of a community than a competition like it is at Napa. So yeah, and there's so many. There's like, I don't know, 300. It's crazy. But it's been fun. That's been my Mike and I are kind of hobby thing. We started out like we were do beer tasting and stuff like that, and then he got this job, and we moved on to that. It's nice because you don't have to drink as much either. You can just kind of sip, and we still enjoy beer for sure. But the whole wine thing's been pretty fun, seeing him learn about it and get really educated in it. And my favorite thing now is like he knows he's like on his way for sommelier and stuff, so the pairings with different foods and all that fun stuff, and doing it economically, because I'm definitely not a big spender. I tend to I'll have things because I get them at a discount, essentially.
You said what's sommelier?
Oh, it's like someone who
can like name wine from different regions.
Yeah, like they're able to like smell and taste something, and they'll be able to tell you like, oh, this is the varietal, this is where it was probably grown, this is even maybe like the year, the vintage that it was. Yeah, like the highest
That's
level.
That's a thing?
It's crazy, yeah.
They're like this had the cows grazed it before we harvested it. The fertilizer.
It goes so detailed. Be like, oh, this was like a south-facing slope,
No.
Things like that, because all these things make a difference. If it was like dry farm versus irrigated, where they just they'll do dry farming here because there's like a lot of calcareous soil that soaks up the water and acts like a sponge and holds the water. Not everywhere, but that really changes based on the year. Like, oh, this vintage was good because it rained super good this year, then the next year I don't understand it or want to pretend to, but it's impressive, like the amount of science and art goes into like making good wine, and I'm just like, I'm impressed. And it's I love hearing them talk about it, and being with a industry person when we go tasting, they like really nerd out about it. And they'll bring like their AVA map, which is American Viniculture Area, and they'll have like, oh yeah, here's the Templeton Gap, this is where the wind blows, and this is why this time, and you get the ocean air or whatever, and then they'll bring out a cylinder of soil, and this is like our different soil types. It's like, wow, they're really bringing a lot of things together.
It's a hobby.
Yeah, totally.
All right, anything you want to say before we end to anybody watching?
Oh, yeah, just enjoy what you do, like being a nurse is honestly really rewarding and awesome, and I'm super stoked to see you going into it. I'm obviously not all of your listeners are nurses, probably not very many of them. I don't know, but
I don't know either.
But
I mean, it's interesting. Like, it's funny. Like, it's just uploading something on YouTube, and then it's there's people that watched this video. Like, who would have ever thought?
Oh, totally.
Like, who would want to watch me interview somebody? But there's like
people do it.
It's funny. It's hilarious. But
yeah, I would say then that definitely easier said than done to like do something that you enjoy, but essentially try to do something that you enjoy, and if it's not at work, that's probably the most common thing. But just being there, being present. There's some studies that show that one of the largest determinants of happiness with like elderly people and how their life was is connection. So finding connection with other people, with animals, with nature, whatever it is, just that you feel present and connected. I just feel a lot happier when I pursue things like that. So whatever that means for you, I would go that direction and, listen to all of the old people in the data that they took for that. And it seems to go pretty well,
Okay, hell yeah. Thank you for coming on. I appreciate
sure.
you, honestly. Of course,
yeah.
I really do. I've had a great time, and
it's been fun.
Excited for